I want to take this opportunity to introduce Dr. Barton. Dr. Barton is our pediatric movement disorder specialist. He graduated from the University of Louisville. He did both his training in child neurology and he had a special training in pediatric movement disorder here at Louisville. He's been with us for the last 2 years. And his special interests are pediatric movement disorders, including Tourette syndrome, dystonia, and he also has a lot of passion for education at medical school, resident, and fellowship levels. With that, I will let Dr. Barton start his presentation.
Perfect. Thank you, Dr. Javare. I appreciate it. I'm going to follow up on a lot of things that Dr. Schwager kind of introduced, and we're going to do more of a bird's eye view of common questions that I often get from both families and in the community concerning pediatric movement disorders. First off, no disclosures, but I will discuss a number of medications that we use off-label. And I'm using a couple of videos here, a few with patient permission, and then the other are from open sources. Kind of an overview, the roadmap for this talk, I want to look at 3 main things. So number 1, what are some common pediatric movement disorders? There are a number of them, so I'm going to focus on the 3 main ones that I tend to see. Number 2, what are common workups? And number 3 is treatment. Number 1 question I ask is, well, what is a pediatric movement disorder? So kids do weird things, right? They do weird things all the time. It can be really tricky to know, especially in young children, what is a normal part of development versus what is something abnormal that we need to do something about. So when we talk about movement disorders, we talk about kind of 4 different types of things. So the impaired voluntary movement, so that means I'm trying to do something, but I can't do it right. Dysfunction of posture. So this is just kind of withstanding that you have difficulty doing that. The presence of abnormal involuntary movements. So movements that aren't normal movements and you do them and you don't mean to do them. Or number 4, which is you do normal stuff, but you do them at the wrong times. Pediatric movement disorders are very different than what our adult neurology colleagues take care of. By far and away, tics are the most common thing that we see, followed by dystonia and tremor. So we're going to focus on some of these most common ones today. The 3 things that we see, so I'm going to pull up a couple examples here. So number 1 is by far and away, we see tics. And I've got a number of examples here of tics. We've got a patient here on the top left with a number of tics, including eye rolling tics, eye blinking tics. You can see some facial movements as well. The patient below, there's no sound here, but this patient is making some cough-like movements, is doing some head shaking. And then the top patient, eye rolling. As you have a number of patients with eye rolling tics, and you can imagine that this gets them in a lot of trouble at school or with their parents. So what are tics? Tics are sudden, rapid, recurrent, non-rhythmic motor movements. So these are things that are fast, they're quick. They tend to be recurrent, but they can be very different and don't follow a set pattern. We like to divide them into both motor and phonics, so motor and noise tics. And these can be simple versus complex. So meaning it's a small movement that they do or something that is much more extravagant. Bottom line, any movement can be a tic. So examples of motor tics include things that we saw. So we saw a lot of simple motor tics in these clips. So eye blinking, head shaking, facial grimacing, shoulder shrugging, or it can be much more larger movements. I have one patient who leans their head back so far that they tend to pass out. Head snapping tics, they can be repeated gestures, and even what we see, copropraxia. So these are kind of obscene gestures patients do. You can also have vocal tics. So the most common vocal tics are things like sniffing, coughing, throat clearing. You can imagine that oftentimes these patients are treated for allergies or recurrent infections before people figure out that it's more of a tic. that's happening. And they can be words or phrases. So long out phrases or cussing tics, which is called coprolalia. How do you know it's a tic? So I like to describe to doctors and patients that treating tics is like treating whack-a-mole. It kind of comes out of nowhere and it's unpredictable. And once one comes up, another one may come up. So that this is speaking to the waxing and waning pattern that we see in tics. You often can get new and old tics. So if you get patients with tics together, they may actually trade tics back and forth. We're actually seeing this phenomenon a lot with social media, where patients are watching videos of people with tics, and then now getting those or incorporating those. So that's been a new thing that we've had to watch. These can fluctuate in frequency and intensity, and you're going to notice that it is much worse during periods of stress, anxiety, excitement, fatigue, or infection. The urge is also really important. This is not perfect in kids. Only about 37% of kids will talk about an urge. So they'll say, well, I clear my throat because I feel kind of either the need to do it, or I feel kind of a scratching kind of feeling in the back of my throat. So I clear my throat, or I blink my eyes because my eyes feel itchy and dry. So I feel the need to do it. In adults, about 90% of patients will express this urge, and that can be really, really helpful to know that that's a tic. I've also found in my experience with young kids, they may not be able to express an urge, but they may be able to say, okay, well, I can control it because I feel it coming on for maybe 5 seconds, 10 seconds before it comes out more. Which brings up this question. I get this question a lot from parents. Can tics be controlled? A long time ago, tics were considered more of a psychiatric illness back in the 1980s. And what we figured out is that it's more of a neurologic basis in the brain. And so I like to use this analogy to help parents understand. They're saying, well, if they can control it sometimes, why can't they control it all the time? And a lot of patients will talk about tics being like an itch that they need to scratch. Like, you don't have to scratch that itch, but gosh, you're going to, right? It gets really annoying. And so that's what a lot of our patients feel. I had another patient, which I wish I had video of, but I asked him what his tics feel like, and he said he feels like he's a Coke bottle that's just been shaken up, and one day he just has to explode and all the tics come out. I think that's just a beautiful analogy to kind of let us know, hey, these are what our patients are feeling. We can also break down tics into common tic disorder. So number one is provisional tic disorder. We used to use the term transient tic disorder. So these are motor and vocal tics that last longer or less than 1 year. This is very common. It's not uncommon for kids to have tics that come up for a couple months and then go away. The definition of Tourette syndrome is greater than 1 year. So we used to use transient tic disorder, but that didn't make any sense, because if you had tics for 364 days, you had transient tic disorder on that 365th day, you then have Tourette syndrome. So provisional tic disorder makes more sense because we're giving you this diagnosis provisionally, seeing what happens. You can also have isolated just motor tics or isolated just vocal tics. This is something that can happen by itself. And then Tourette syndrome, by definition, means at least 2 motor tics and 1 vocal tic that don't have to be present at the same time, but just exist. And you need to have them longer than a year and no tic-free periods longer than 3 months, as well as being under the age of 18. Most of the time, we'll see patients present younger than this, so usually under the age of 12, though there are cases of presenting a little bit older. What is first-line testing? So when you see patients, most of the time, if they fit a definition, we don't need any further testing. In the past, sometimes thyroid testing was recommended. This is no longer recommended for thyroid testing unless patients have symptoms that are suggestive of hyper or hypothyroidism. So I tend to do a good review of systems when I see these patients. But otherwise, if they don't have symptoms, we can hold off testing. And most patients can be diagnosed clinically. In terms of prognosis, kids tend to peak between ages 8 to 12. And so we'll often see tics come up around 5 years of age. I've seen it much younger. We can see kids who present at 2 to 3 years of age with tics. And it will often improve as they get older. A good rule of thumb is the rule of thirds. So a third of adults with Tourette syndrome stop having tics altogether, a third of them get better, and then a third of them stay the same and get worse. And only 10% of kids with Tourette syndrome need medication as adults. So that's helpful just in counseling your families that most of the time this is a diagnosis of childhood. But do know that they are often worsening in times of stress, when kids are sick, when kids are sleep deprived. So we often see kids present in July right before school starts with worsening of their tics. We see it during the winter. And as you can imagine, in the last year, we've seen just huge increases because we're stressed all the time, just with COVID and the different precautions that have been undertaken. The most important thing to know about Tourette syndrome, and again, Dr. Schlager did a great job of kind of talking about this and alluding to this, but are common comorbidities of Tourette syndrome. So we know that kids with Tourette syndrome have other things that go along with it, often have mental, behavioral, developmental conditions. And these are almost always, especially in younger kids, more bothersome than the tics themselves. And about 86% of kids have one condition. So this is, I use this for families a lot, and have found it very beneficial. This is created by the Tourette's Association of America. And I like to say that kids come in to see me, parents bring them in for the top stuff. So for the motor and the vocal tics. But it's the stuff below that really causes them problems. So the things like ADHD that's unrecognized, anxiety, OCD, rage, sleep issues. Many patients with Tourette syndrome have handwriting difficulties. So you can imagine that being 5 or 6 and going through writing class can be really difficult. Bullying. These are things that I tend to really screen for, really talk about. And they're tough because they will make the symptoms of tics worse. So if you are seeing patients who have worsening symptoms, you want to check these things. This is breaking down by age. So ADHD, a lot more common in boys, and anxiety, a little bit more common in girls, but something that we see very commonly. Coprolalia. So this is something that I get asked out about a lot in any new diagnosis of Tourette syndrome. This is always a question that I get from parents. What about the swearing? It's pretty rare among kids with Tourette syndrome. So anywhere from 2 to 10, though I would say 2 to 5% have coprolalia, though again, I'm seeing a big increase of that in the last year just related to social media experience. So if you are seeing patients who are doing this, I really do recommend a social media fast, because that is allowing people to connect in ways that has been a little less helpful. And the reason parents think this is because of the way that Tourette syndrome is portrayed in film and television. So these are examples of movies and TV shows. I'm sure not everybody here has been exposed to South Park, but there was an episode where a character came into school and had Tourette syndrome with cussing. So the other kids thought, okay, well, we can say we have Tourette syndrome and now we can swear all we want to. And this creates a really bad perception among really the general public. So a lot of our job is really trying to educate parents that this is not what Tourette syndrome looks like the most time, really trying to build self-esteem and build education. And most of these media portrayals focus on, abnormal comments, abnormal cussing, when again, that's not something we see in most patients. How do we treat tics? Most patients don't necessarily need medication. They can be treated through education or just watchful waiting. There are some new behavioral therapies, which I'll talk about, as well as medications. So how do we approach treatment? Number one is identifying the most severe comorbid condition, really trying to focus on that and really reserving treatment for tics, just for tics that are functionally disabling or don't respond to other treatment. And I always counsel, if we are going to use medication, there's no medication that exists that makes tics go away. The goal is expectation setting, that we're just trying to make them not as bothersome to improve function and quality of life. CBIT, that Dr. Schlager talked about a little bit, is an offshoot of habit reversal therapy. We have a number of CBIT therapist. So that stands for Comprehensive Behavioral Intervention for Tics. We have a number throughout the state as well as a couple here. And there are a couple really nice national services that provide this too by telemedicine. And this is recommended first line by the 2019 American Academy of Neurology Tourette guidelines. But it doesn't work for all kids, especially younger kids. So you need three things. You need to have that urge. So as I said, younger kids don't always have that urge. You need to want the tic to go away. Some kids, believe it or not, actually like their tics. And we kind of try to focus on one tic at a time. So this is really, really beneficial. This is something where if you've got patients that you think need this, we can see them, see if they qualify and refer appropriately. There are medications that are used. And so as we talked about earlier with some of the studies, alpha-2 agonists like clonidine and guanfacine tend to be recommended first just because they have the fewest side effects. Topiramate has a lot of good evidence. And because of the side effects of dopamine blockers, I tend to try this first if this seems like a good option just because of the side effects. Dopamine blockers like aripiprazole or risperidone are beneficial, but do have, risperidone are beneficial, but do have a higher side effect profile. And there are other options, including neuromodulation, like we talked about in the last talk with deep brain stimulation, but this is reserved in adults, not kids, because most kids grow out of it. Transitioning to a common mimicker of tics. So this is something we see in younger kids. And I often will get referrals for patients like this, usually for concern of seizure. And these are some really good examples of kids who are having stereotypies. You can imagine the kid in the middle, especially with some of the shaking and the stiffening, that could be concerning for other things like infantile spasms or other types of seizures, but is consistent with stereotypy. So what are stereotypies? These are involuntary, rhythmic, repetitive movements that kids do. They serve no purpose, but they do look purposeful. I like to say that they happen during periods of engrossment. So when kids are overly excited, overly sad, it happens a lot when kids are eating or playing, and it has this fixed pattern. So unlike tics, where they just kind of wax and wane and change over time, and they get new ones and old ones, stereotypies tend to be the same thing over and over again. The key is to evaluate other disorders, so things like habits, mannerisms, again, tics, which I'll break down a little bit more here in a second, or a lot of referrals I see are for seizures. So tics versus stereotypies. Stereotypies tend to present younger. Most kids present before 3 years of age with some stereotypy. And usually if you're seeing kids at an older age, you go back and you find out they've been doing it forever, but maybe it just increased or become more noticeable. There often is a family history, and the duration is not as much. And these tend to not be as quick or as jerky, but a little bit more kind of playful type of things that kids will do. The number one question that comes up, so any parent who Googles stereotypies, if you give them a diagnosis, their number one question is, does my child have autism? And this really comes down to this idea that stereotypies can be broken down into primary versus secondary stereotypy. Primary stereotypy happens in most kids. So kids under the age of 2 typically who are otherwise developmentally normal, I'll give them a diagnosis of primary stereotypy. The key with patients like this is a screen. So make sure that they don't have other developmental conditions that make you worried about a secondary stereotypy. So autism, but you can see that in other things like just developmental delay, ADHD, Rett syndrome. It can also be an early sign of patients with sensory deprivation. So patients with vision or hearing impairment can often have stereotypies. Most of the time, we don't need to treat. Patients do well. In rare cases, we can do habit reversal therapy where occupational therapists can treat this, but most of the time, if you educate and discuss, and then children often, as they become adults, get really good at hiding these or making these part of their normal activities. So I'm going to end with the last topic here.
All right, I want you to put your hands up like this.
So this is a patient that I took care of with a diagnosis of new onset tremor.
Okay, good. I want you to put your hands out again.
And I'm going to come back to this video in a second.
Take your left, your hand.
But tremor is also a very, very common referral that we'll see in child neurology. So this is oscillatory around the point. So that means rather than jerkiness like you'll see with some other movement disorders, this tends to be there's a central axis that you're kind of working around or moving around, either up and down or around. And the evaluation of tremor really requires looking for other causes of things that can make it happen. So when should I be concerned about tremor? These are the different characteristics of tremor. Tremor can happen when you're at rest. They can happen in action. They can happen posturally. They can happen with movements. Most of these are normal. So action tremor, and I actually have a little bit of a postural tremor as well. Most of these things, when you see action, postural, kinetic, are normal findings of baseline tremor and aren't things that need to be concerned about. Rest, when we see tremor at rest, tends to not be normal. That's something that requires evaluation. And I'll talk about that a little bit more in a second. Intention, so this means tremor that only really happens when you get close to an object. That makes you more concerned about a cerebellar pathology or something going on in the cerebellum in the brain. Or if it's task specific, so tremor only comes when they do certain things. This can be suggestive of something like a dystonia that has come up. So we classify tremor in three main ways. So number one is enhanced physiologic tremor. So we kind of take for granted that our body is constantly tremoring, relaxing and contracting muscles to make us stay straight. And so physiologic tremor is that baseline tremor, and this comes out a lot more with certain things. So if you drink a lot of caffeine, or if you've ever taken a albuterol and get shaky hands, this is your normal physiologic tremor that you have all the time that just become more pronounced. It can happen with stress. This is the type of tremor that we see with medications as well as with thyroid hormones. Essential tremor, so this is a tremor that runs in families. Even though we think about essential tremor presenting in older people, that can often present for the first time in young children. So I will see teenagers who present for the first time with this, as well as what we are most concerned about, symptomatic tremor. So this means tremor caused by something. So this could be medications, this could be something going on in the brain. So our key is to really try to evaluate this. When I see patients with tremor, the number one thing I want to make sure is that they're not on a medicine that may be causing this. So we'll see a lot of patients on stimulants or certain medications like SSRIs or dopamine blockers that can bring it out. Valproic acid is a medication that is very well associated with tremor, as well as immune modulation therapies like cyclosporin or steroids. How do we work up tremor? So rest versus action. So rest tremor, like I said, is never normal. And when we see patients with rest tremor, we're looking for things such as Parkinsonism that may be bringing this out. That's rare in children, but something we see. The other thing that is very important to know that can cause rest tremor, and we kind of saw this in our patient who was at rest, is actually a functional neurologic etiology. So this is the old term conversion disorder, but caused by a functional cause. So I'll talk about this a little bit more in a second. You can also get action tremor. So most tremor that you see in your clinic will be action mediated. So again, screen for medications. If there's a medicine that can be weaned or taken off, try to do that on a slow wean, because fast weans can actually exacerbate tremor. And then if otherwise it's postural with no worsening, I usually see those kids back in a year, 9 months to a year, just making sure that there's no worsening, make sure that they have a normal exam, that there's no other cerebellar problems, so things like problems with swallowing, coordination, falls. But if you are getting intention tremor, an abnormal exam, or worsening of those symptoms, that's what makes you worried about something going on, and that's when we think about brain imaging. Some medicines can be used, but most patients don't need them. So if you are worried about essential tremor, propranolol or primidone used at low doses. Again, the key here, just like we're talking about tics, is go low, or start low, go slow. And other medications can be used as well. And real briefly, just because I used an example of functional neurologic disorder, how do you know that patients that you see in are dealing with a functional etiology. So that means something that we used to use the term stress-induced or conversion disorder, but this means that there's kind of a brain network issue that is going on where kids have developed these symptoms. And we're seeing a lot of this just with the increased stress that has been under all of our country, but especially in our kids. And so there's three things that we look for: variability, distractibility, and trainability. So variability means that it changes throughout how people move. Distractibility means that you can make it go away or make it really decrease by having them do other things. And then the most important thing is in trainability. So can you make it match a certain pattern? So I'm going to bring up this video again, just to highlight a couple points that we're seeing here.
All right, I want you to put your hands up like this.
So you can see that as she's moving,
Put your hands close
and you
together.
move it closer, she's got a lot of change in the way it looks and
I
in
want
the
you to put your
frequency
hands out
here.
again. And I want you to take your left hand, and I want you to open and close it slowly.
Fast forward a little bit. So you can see,
And I want you to
when
take the left hand still, and I want you to tap like this.
so when she taps, you can see that you can make it go faster and slower,
Slow.
the tremor change. So this patient was diagnosed with functional tremor,
Okay.
actually got rehab, and is totally normal. So she's doing wonderful. So that's an important etiology to recognize. So in conclusion, movement disorders can often happen in children. Video, as you've seen, can be really helpful for diagnosis. Knowing the type of movement helps with workup and treatment, and then behavioral therapies like CBIT are really helpful for certain disorders. Any questions that I can help answer?
Thank you, Dr. Barton, for explaining the movement disorders basics. I do have a questions. One is, when should we consider additional investigation when we are clinically diagnosing someone with tics?
Really great question. So a couple of things that I look for. Number one is systemic symptoms. So thyroid etiology is something that's important to pick up on. So patients who have fast heart rate, even at rest, that they have heat intolerance, they have increased sweating, they've had diarrhea or weight loss. Those are things that I'll consider a second etiology. Otherwise, other metabolic disorders or autoimmune disorders that cause tics tend to cause some other movement disorder. So they tend to cause balance problems, they tend to cause other movements. And so I'm usually screening for that. If it's isolated tics, for the most part, they don't need further testing.
Thank you. Dr. Mendoza wants to know where are the locations of the CB, cognitive behavioral therapy for tics in Kentucky?
Yeah, so there's a couple that we use. So here in Louisville, we work a lot with Spalding University has a provider named Jocelyn Warren, who actually is teaching different occupational therapist students. So we have a number of patients that work through her. So you can refer to her, and Dr. Mendoza, I can get you that information. We've trained a number of providers at Associates in Pediatric Therapy here throughout the state who are also trained in this. And then I've started using tichelper.com. Which has been really helpful. This is a national based CBIT provider because most patients have gone virtually anyway. So that has been a benefit of the virtual platform, as we have that option now.
There is also a request if you can share the online CBT, resources with everyone.
Perfect.
Ms. Allison is asking whether any medication can be tried for bothersome stereotypies.
Really, really good question. So no medicine has really been shown to be helpful with stereotypies. And stereotypies, if they are really bothersome, can be tricky. Habit reversal therapy tends to be the best option. I would also really look for other behavioral interventions. So in terms of if you've noticed that there are certain triggers, this can be really tricky with patients with autism, but looking, are there certain environments that bring it out or certain stresses? A number of occupational therapists will do habit reversal therapy as well.
So, Chris, can you hear me?
Yep.
So actually, that was a great question. And and in fact, I asked that question of Harvey Singer at the meeting when we were in Vancouver, if you remember.
Yep.
I asked him the same question because I had a patient at that time from Bowling Green with very, very bothersome stereotypies. And so basically, he said that he had limited experience, that he had some success with, Abilify. And I think, and maybe some other drug that he may have mentioned, but maybe Abilify, some limited success in that situation with severe stereotypies.
Yeah, and so talking about stereotypies, so Dr. Singer at Johns Hopkins, so he is the #1 published person on stereotypies in the country. So most of what we know about stereotypies comes from him. Most of the trials where they looked at dopamine blockade didn't show any statistical benefit, but it's definitely, again, because of a lot of comorbid conditions that you see in patients, it's definitely worth a try. So I have a couple patients with stereotypies who we've used dopamine blockers, sometime with mixed success, but with patients who, again, because it can help with the things that bring them out more, is definitely worth a try for sure.